amount of pressure that's sufficient is just so that your fingernail blanches, or thumbnail, whatever. That's typically for like diagnosis, if there is a response there. For treatment, sometimes you typically use perhaps a little bit more or a little bit less, depending upon the patient's tolerance for sensitivity. So I just wanted to kind of review the location of the primary trigger points that we're going to be going over. And so you've already learned these, but just to reiterate. There are the suboccipital trigger points, which are in the suboccipital region. There is the posterior cervical trigger points, which are opposite C5 through C7, right? So that's not a real discrete localization. There are other trigger points which are like one spot, but this kind of has a bit of a range. There's the upper trapezius trigger point, which is in the belly of the upper trapezius muscle here, which is typically right on the tippy top you get the curve going from anterior to posterior. It's pretty much right on the top there, okay? And then the supraspinatus trigger point is a little bit posterior to that one in the belly of the supraspinatus muscle. The levator scapular trigger point is at the medial superior border of the scapula. Now, this is an attachment trigger point that's primarily being treated here. The other trigger points are considered more central trigger points, which means they're like centralized or more in the muscle belly. There's the infraspinatus trigger point, which is in the muscle belly of the infraspinatus muscle, and the teres minor, which is, if you come up and you find the axillary fold and then the lateral aspect of the lateral border of the scapula, that's where the teres minor would be. So those are the ones we're going to primarily focus on. There are some in the lower one as well. So this is one of the ways that you can identify them with the patient being seated, right? So you can kind of come up here and find them after you do some other exam things. You can kind of check out that location for them. So in a prone position, it's always helpful to be able to localize the trigger points in a variety of different positions. Supine, prone, seated, like that. So in this position, I can use like my middle fingers, because they're just the longest ones, right? So they kind of get there first, or I could use my thumb and index finger, whatever kind of works. So that's would be the suboccipital. This would be the posterior cervical. You can find the upper traps, supra, levator, come out here, infraspinatus, and kind of in here, teres minor. So, and then we also have down here, this is the lower lumbar. The gluteals would be kind of out in here. So in the notes or the slides, we showed various kind of techniques. The one that I find is probably most therapeutically valuable to really get in and work it out is to use the elbow technique. We did learn, and then you have skin rolling, which can be used in a variety of different body parts, particularly where there's a little bit more of a looser skin. Like you might not be able to do skin rolling so well on the thigh necessarily, or the calf muscle, because you just can't really pick up stuff. So it tends to be not necessarily localized, but very commonly used in the thoracic or the lumbar region that way. The intercostals, you can use your finger and you just kind of go in between the muscles of the ribs, and that kind of helps that. But the most important that I find is to use the elbow technique. And I know that in the picture, the guy was like laying there like that, like he was just kind of hanging out on a park bench or something. Also using a neuromuscular technique, particularly with this kind of application, it certainly works better if the patient is disrobed. Men usually they leave their pants on or whatever. Women would put a gown on. Men would put a gown on, open towards the rear, so you have access, and then you have those the tissues that you can work with. And so sometimes to do that, it works better with a little bit of lubricant. So you could use lotion, tiger balm, cocoa butter, Traumeel. That's the one I tend to use primarily, is Traumeel, because it's not odorous. You could potentially use, a DMSO cream. And you could probably have people compound a cream specifically for you that might have anti-inflammatory stuff in it, or pain-relieving materials kind of embedded into the cream, so you could use that. I just tend to use Traumeel. There are other creams like that you could use, so that way it gives you a little bit more like flow. But as an example of that, for using the elbow, my one hand is kind of like this, so I have the V here, right? So that V allows me to stick my elbow in it, so that I can use pressure with my elbow. Sometimes what happens, this is much more easily understood if you've got lotion on here. You're like, you can kind of like slip and slide like you're on ice. And so this hand provides a guide.
So you kind of come through, and then you can, find spots. You can, stop if you find a spot, kind of rotate your humerus kind of this way, like a screw, and that kind of provides a little bit more pressure. When I get to the area on the top here, one of the things that I can do, I have to kind of move my hand as a guide kind of out of there. But then, as you can see, I can internally and externally rotate my humerus by moving my forearm. And so I kind of, you can see how I get this range. So I can kind of go all along that upper traps and super area. And if I wanted to do the other side, I usually would do the same hand, because this one, I guess I could do it that way, but then this hand could lead, right? So, and then kind of do very much the same kind of thing. And like I said, it does get a better flow if you've got, lotion and just your elbow on the tissues. And so that's doing it in a prone position. So let me describe or demonstrate doing it in a supine. So let me turn over. So these are very much are, they are neuromuscular type techniques, which are soft tissue techniques, which again you're doing before you do manipulation typically, or these could be done by themselves, depending on the nature of the individual's complaint or how much they might be in an acute kind of space and like that. So even in the supine you can find suboccipitals, posterior cervicals, upper traps, supraspinatus. I tend to come down like this to find the levator scapula, kind of come underneath here. I can find the infraspinatus, kind of come out here like this and find the teres minor. So again, I can treat all of those if a person had a cervical thoracic junction issue, cervical issue, and I can work all that out. So for the upper area, you probably want to palpate his because his C1s are really easy.
Oh, okay.
So you get that better sense of it.
Right?
Yeah. So one of the ways to do this therapeutically, I'm going to stick my whole hand through the other side and then use my thumb. So I'm like this. So my thumb is there, kind of like an arch in some respects. So my other hand is just holding him like I would be kind of using the cradle hold. All right. So his head is kind of rotated, which allows me kind of access. Like I said, this hand just goes all the way through. My fingers aren't really doing anything. They're just hanging out. All this is basically happening with my thumb. And I let my elbow rest on my thigh, so it just gives me a little more kind of comfort and support, because this, again, allows me to be buttressed. And, a triangle is kind of like the strongest thing in nature, right? And so then what I can do is just make little circles with my thumb. And this is on C1 right here, because the suboccipital muscles insert on the transverse process of C1. And then you've got the occipital ridge. So I can just do little circles along the occipital ridge, going all the way down kind of to the center point of it. I can, go down the articular pillar as well. And so that way you can get, primarily the upper cervical and cervical vertebra, soft tissues, muscles. Now, if I want to get more pressure, not necessarily do I have to kind of push that way, I can just use my other hand, just rotate his head over onto my thumb. And then, kind of putting the coordinated use of both hands together, I can make circles. Is that pressure okay? Mm-hmm. And is it, any sensitivity produced? Oh, yeah. All right, is it local or does it radiate?
It radiates actually.
All right, so he's got the trigger point. So those are questions when you're doing therapeutic application. Is it sensitive, local, referred? Where is it referred to? And yes, this is a trigger point. Yes, this is a tender point. Even though, for the most part, you're going to be treating them the same. And again, other techniques for treatment of trigger points, in addition to ischemic compression, which is the neuromuscular technique, would be acupuncture. It could be injection. You could do laser on it. There's a variety of other ways that you could do things. So again, I'm working them out this way to get to the other side. So my hand is just like this, like it would be in the cradle hold. Kind of rotate his head, and so I'm cupping his ear. So this is similar very much to all the manipulations, right? I always tell you, get your index finger in the suboccipital area, cup the ear. So I'm not squishing it, so it's kind of cupped. So sometimes you might have to be, aware of earrings and stuff like that, so you don't squish posts or get stuck in hoops and things like that. For the most part, easy earrings aren't really a big deal. But if they seem like they're in your way, just have the person take them off. So my hand is like this. So again, I can just rotate them over. This hand again, like I said, just kind of comes in just like this. And my fingers are just kind of like over there. And then my thumb is just in that region. So this is the part of my anatomy that I'm using to be the therapeutic pressure applier. And again, you can see I'm resting on my thigh here so that, This, I could do this, but after a while I'm holding up my extremity kind of in the air. This way I'm able to relax more so. And then again, I can use pressure. Is that pressure okay? Same kind of thing, radiation or no? All right, so if I find a spot that's particularly fibrous or particularly sensitive, I can spend a little bit more time there. And I'm sure you all are familiar with the term "it hurts good." So you want to find if there is the hurts good, and make it hurt good. You don't want to make it hurt bad, so you want to be on that edge, but you also want to make it be so like mild that nothing's happening. But again, that's in terms of the patient's susceptibility or sensitivity. So you could use very light pressure and still have it be therapeutic, or you can get a little bit more deeply in there depending on their own tolerances. And so as you're doing this therapeutically, the other side of that coin, as I talked about in class with expressive manipulation and intention, your own healing energy is creating a response, and so it's being directed like into the person's body, right? You're sending your juice in there. Of course, at the same time when you're doing that, you're getting the patient's juice too. So that's why you need to have that protective kind of quality, which again, white light or breathing or just awareness kind of makes that boundary, so you're not going to be quote unquote taken advantage of. But this isn't just simply that kind of biomechanical. You're actually. That probably looks good on the video.
Yeah. Very robotic.
Yeah, so you're not robotic about it. You're clinical and healing, about how you get in there, and you find those spots. And then when you're doing this, clinically speaking, again, you could be, did you see that game last night? Man, the Lakers really sucked, got their ass kicked, blah, blah, blah. How's your kid? How was that trip to New York? Blah, blah, blah. Or you're just quiet. The other thing that's really important is observe their breathing. It's my experience that quite often when I'm working on patients, I'm like, they're dead. So it's like, take a nice, no. They're just not breathing.
Oh, okay.
So that, they appear to be dead because they're not seeing any kind of respiratory stuff. So it's really helpful. Take a nice deep breath. Let me just have you, get into a nice routine of deep breathing. And a lot of times when you want to apply a little bit more pressure specifically, that's a little bit more, forceful or well, no, I don't want to use the word invasive, but a little bit more pressure, that can be applied with an exhalation. So it's like, okay, take a nice deep breath in. All right, as you exhale, you just kind of get in there and get a nice, a little bit more pressure. And then when you're finished, as a stretch, you can do kind of a modified shoulder depression type test. So this hand is just holding his, occipital head. Push him down, just push him over. And then this hand just kind of comes in there. You just kind of flip over. So my fingers on the other side are kind of like, using them to pull while this is kind of doing that. And so you'll just, be able to kind of find that spot. And the advantages of the rolly stools is that you can go kind of back and forth to give yourself leverage and position. Okay? So let's try these. You can kind of run through this. And then once we've done this, I'm going to demonstrate, we're going to re-practice the bridging traction, bowstring traction, and suboccipital traction, which are also excellent for the cervical region. And then I'm going to demonstrate